All right, welcome to Care Without Borders, expanding and enhancing eating disorder treatment through remote delivery. My name is Lydia Rhino, the program director at the Eating Disorder Foundation, and I am excited to welcome everyone here tonight. Today's workshop is brought to you in collaboration with the Eating Disorder Foundation and Within Health. I'd like to take a moment to share a little bit about the Eating Disorder Foundation. We are a nonprofit that was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver based organization that is now serving individuals and families both nationally and internationally. I want to thank anyone who made a donation upon registration. We are able to provide free services because of the generosity of our community. I will add the donation link in the chat if you wish to contribute. If anyone has any questions for our presenters this evening, I invite you to use the chat feature to communicate with me directly throughout the workshop. The chat is kept confidential and will come to me directly. We will save time for Q&A after the presentation, and I will deliver the questions to our presenters. We will not be sharing the PowerPoint. However, we are recording tonight, and we'll send the recording as soon as possible. I'm going to take a second to introduce Within Health and our speakers for the evening. At Within Health, every patient is matched with a compassionate expert team to develop a personalized treatment plan that prioritizes long-term recovery and individual goals. We offer enhanced 100% remote PHP and IOP levels of care, treating individuals aged 13 and up. We specialize in treating primary eating disorders, disordered eating, and co-occurring conditions, and are currently serving 43 states and counting. As a physician-led healthcare organization, we are driven by a commitment to innovation, compassion, and integrity in all we do. Our team is focused on making a meaningful impact in the lives of everybody, everywhere. And introducing our speakers for the evening. Rebecca Brum, Chief Clinical Officer at Within Health, brings nearly 2 decades of experience and heartfelt dedication to her role. A proud graduate of Central Michigan University, Rebecca is deeply committed to the integration of mind, body, and soul, an ethos that shapes both her leadership and clinical approach. Since beginning her career as a therapist in 2005, Rebecca has guided clients through a wide range of mental health challenges. She is especially passionate about helping individuals improve body image, rebuild self-worth, and recover from eating disorders. Her work is grounded in compassion, authenticity, and a belief in the transformative power of healing from within. And introducing our second speaker of the evening, Caitlin Shepard is the Clinical Research Director at Within Health. As a licensed psychologist and research affiliate at Smith College, she has over a decade of experience in the eating disorder field. She earned both her MS and PhD in counseling psychology from Colorado State University, and then completed advanced clinical and research training in the eating disorders program at Weill Cornell Medical College, New York Presbyterian Hospital. She has extensive research treating individuals with eating disorders and other mental health concerns in a variety of settings across levels of care. She has also held faculty positions at several institutions, including Wesleyan University and Smith College, where she taught clinical and research-oriented courses and managed an eating disorders research lab. As a researcher, she has published articles in peer-reviewed journals and presented at numerous regional, national, and international conferences. She is an active member of the Academy for Eating Disorders, currently serving as the co-chair for the Educational Programming Committee. All right, and with that, thank you both for being here with us tonight. I am so excited to hear y'all share on the Care Without Borders, expanding and enhancing eating disorder treatment through remote delivery. And I will hand it over to you both.
Great. Thank you, Lydia, for that introduction. We're excited to be here as well. And we'll go ahead and just get started. So our plan for this presentation, so we've already done the welcome and introduction, but we've sort of broken it down into a couple different areas. So we want to first talk about some of the barriers to eating disorder treatment, but then also look at the key benefits of remote care and kind of where the opportunities are there. And we'll kind of talk about that broadly and then use what we know from our work at Within Health and sort of use that as a case example in terms of some of those benefits and what that can look like. Then we'll spend some time talking about still some of the challenges that might come up with remote care and clinical considerations, as well as thinking about adaptations, especially technology innovations that we might be able to leverage in this kind of environment. Um, and then wrap up with talking about outcomes. So as we talk about all of that, then getting to is it effective? Does it work? And spending some time kind of going through that as well. And then hopefully leave some time at the end for question and answer. So feel free, as Lydia said, to put those questions in the chat. We already had our bios, but here we are. Rebecca and I will be sharing some of our relative expertise today. And I know that Lydia already did kind of a brief overview of Within, but I'll turn it over to Rebecca to say a little bit more about our model and what we do that is really, I think, relevant to today's talk.
Yeah. Thank you, Caitlin. We did want to give you kind of a rough frame of reference for what we might be referring to tonight as we have our experience as an intentionally remote program. So just so you have kind of an idea of the way that we operate, we again are an intentionally remote, enhanced, evidence-based care model that provides IOP and PHP. And we designed this program to be based on a multidisciplinary approach. So each of our patients, if you can imagine here, this kind of inner circle has a patient team. And then we also offer group experiences and other ancillary services so that the patient has a really meaningful and I'll say traditional in the sense of what might be predicted and expected in a brick and mortar setting to be helpful.
Great. And you'll hear more about the specifics of what that looks like, but hopefully that gives you at least a general idea of kind of where we're coming from. So like I said, we'll get into kind of the key benefits of remote care. But prior to that, want to start with kind of thinking about, why that matters or how we got there. And so this may be familiar territory for some of you. I know that a lot of people encounter barriers to treatment, whether that's for themselves or loved ones or their clients. And so we know that barriers to eating disorder treatment are fairly common. And there's a number of different stats out there, but I know a recent report indicated that only about 30% of individuals with eating disorders seek formal treatment. And that's just seeking formal treatment. And then, beyond that, the number that actually receive treatment or receive, evidence-based high quality treatment, is even smaller. So we're seeing that many people are going without the kind of care that they need. And we see that there are many, many different reasons for that, many barriers, some of which are listed here. I'm sure there are others beyond this. And there are different ways that we could think about these, and even across these categories, they may interact. But we can think about psychological barriers. So some of the things that are maybe more intrapersonal or individual or internal. So there's shame, stigma, denial, low motivation, or at least ambivalence, negative self-perceptions, identification with the eating disorder, right? Difficulty kind of separating or letting go of that. So we have some of these things that might prevent people, especially from, initially seeking that treatment, or may make it difficult for them to continue pursuing that. So we have some of those barriers, which again, then interact with some of these others, right? The shame and stigma is also coming from, society, from sociocultural factors as well. But then we have these sociocultural barriers. So cultural or gender-based stigmas and stereotypes, lack of recognition of eating disorders, especially we might see that more in certain groups, language or cultural mismatches, just in terms of, how we might talk about things or understand things. Also talking about treatment or kind of understanding, even what treatment options exist. Limited social support, so people may not have the support that they need to be able to pursue treatment. Just generally low awareness about eating disorders, or awareness that treatment options exist, negative treatment beliefs, so people not wanting to pursue treatment for various reasons. Beyond that, we have practical barriers. And again, these are numerous. So finances, insurance limitations, geographic isolation. So people may have difficulty finding qualified providers or programs that are nearby to them. So they may need to travel pretty far to be able to access that kind of treatment. Even then, limited availability. So maybe there's a program that is nearby, but it's only available certain times of day, and that is maybe more challenging given perhaps someone's schedule. So time, scheduling constraints, lack of transportation, wait lists, the list goes on. And then finally, this should say systemic barriers, or systematic could be as well, but missed or delayed diagnosis. This is kind of coming more from, perceptions of providers, biases, the healthcare system. So dismissal or minimization, provider bias and stereotyping, clinician inexperience, so not having the experience to treat eating disorders or the training, rigid or inflexible care models, again, negative past treatment experiences that may serve as an impediment. So we see many barriers, and again, there may be more beyond this that help us understand why, we see such a large percentage of people not able to obtain the treatment that they need. This is just kind of a further detail or further example or illustration of that, that is particularly relevant for the work that we do, given our program is at this intermediate level of care, so PHP and IOP. So these maps are just showing the U.S. and showing for adolescents and adults where there are Joint Commission accredited programs, so that have met a particular level of quality based on those metrics, that have both a PHP and IOP, so that would potentially allow someone to transition more easily across those levels of care, as is common. So this is showing the counties in the US where those kinds of services are available. And so the darker colors, there's more, the lighter colors, there's fewer. And then, as you can see, there are many, many spaces and places here that have no purple or no green. And so these are real gaps in treatment deserts where people are not able to, again, going back to that geographic piece at least, able to obtain that treatment at that level of care if they may need it. So this is clearly a problem in terms of the barriers that we're seeing. But it's especially a problem when we think about the impact of these eating disorder treatment barriers. So what that means, given that we know that eating disorders have very severe, significant consequences, with some of the latest reports indicating, every 52 minutes a person dies from an eating disorder. So at the, the most severe end of the spectrum here. And so further, when we look at duration of untreated illness, so some reports have indicated average duration of untreated illness from an eating disorder is about 2.5 to 6 years, depending on the diagnosis for adolescents. And then is about 50% longer when we're talking about emerging adults. So there's some of these stereotypes about eating disorders really being an adolescent issue. And so the older someone gets, the longer it may take for them to be identified or get treatment as well. And so this is, again, getting back to those barriers. We have people who are maybe not able to access treatment for various reasons. They go for these long periods of time without being treated. And then we see these consequences. So there's research showing that shorter duration of untreated eating disorder is, as one might expect, associated with better outcomes, better chance of remission, whereas longer duration of untreated eating disorder illness is associated with poorer outcomes. And again, leading us back to that point about potential fatality being a consequence. So we know this is a problem, and we know that there's pretty significant consequences if we can't find ways to close this treatment gap. And so this is where technology comes in. So telehealth in various forms has been around for decades and has shown some potential as what they call a disruptive innovation or disruptive technology to be able to expand access. However, it historically has remained underutilized. So people were using telephone or using different types of video conferencing for some period of time, but it really didn't take off right until the pandemic hit. In fact, I was doing a presentation at a conference in fall of 2019 that was about telehealth. And I was talking about eating disorders. It was multidisciplinary. So we had folks talking about anxiety and OCD, and it was really novel at that time. And we were getting a lot of questions of, people feeling like, how can you possibly do this work, via telehealth? So that was 2019, and then 2020 happened. We had the pandemic, and you can see this surge early in the pandemic of telehealth. So when people had to shift things to telehealth, seeing that significant increase. Now, this graph here is just looking at telehealth in general. So it includes, medical and includes other behavioral health. It's not specific to eating disorders, but we saw that pattern as well. And so you see that surge during the pandemic, and then, stabilized a bit, and then slowly declined over time, still remaining much higher than it was previously. This only goes to 2023, but it's pretty much plateaued since then, but being lower than it was initially. However, interestingly, this other graph shows that the proportion representing behavioral health has increased. So when we look at all of the telehealth types of visits over this period of time, the kind of more general medical visits have decreased within that proportion, but behavioral health has remained pretty high. I think as people have realized that in many cases, doing psychotherapy or different types of behavioral health treatments via telehealth is effective and it is feasible. So that leads us to thinking about what this means for eating disorder treatment. And there are a number of studies that have looked at this, and I'll talk more about those in terms of outcomes later on. But early in the pandemic, there were a number of studies looking at the feasibility, like, can we do this type of treatment, especially multidisciplinary eating disorder treatment remotely? It is, a bit more complicated and difficult than perhaps someone who has another behavioral health concern where we're needing to think about nutrition and meal support. We're needing to think about tracking vitals and medical care and things like that. So there's kind of these additional pieces. Nevertheless, those studies did find that this was feasible. And again, we'll talk more about the effectiveness piece later on, but spoiler alert is that overall they found that it was effective as well. In addition, there have been a number of studies, as well as anecdotal evidence that we can share too, to suggest that there are benefits of doing eating disorder treatment remotely, kind of circling back to some of those barriers that I mentioned. So these are just some of them. This is not an exhaustive list, but some of the ones that we've really seen in particular, that expanded access and availability. So again, being able to reach individuals in those underserved areas, when we look at that map with all of that sort of blank area, when we are delivering treatment remotely, we can potentially reach people who are in those areas who otherwise wouldn't have access. Therefore, increases access to specialized evidence-based providers and programming. So again, even if you have, a provider or something perhaps nearby, it may not be someone who's really specialized in eating disorders, or maybe you don't have that higher level of care kind of programming that you need. And then also just, again, offers more scheduling options, reduced wait time. So it just really sort of opens up that availability. One of the big things that we've seen is increased flexibility and continuity. So reducing those logistical burdens. So again, travel time. So if you have a PHP program an hour away, so it's theoretically within reasonable distance for someone to be able to go, you're still then having to factor in travel time. And this can be especially problematic for folks who have other responsibilities or other life activities. And so where we have really seen this be a benefit is with parents or caregivers. So they may still be able to, continue to be at home and, engage with their families and those responsibilities, and then be able to kind of fit programming around their life as well. Same with folks who are working and maybe can't take time off from work, or in school, adolescents who maybe we don't want to pull them out of school to go to programming. We can find ways to build programming around their life instead, so that they could, even do some amount of programming in the morning and then go to school or go to work and then do more programming later in the day. So it just provides a lot more flexibility there. Also supporting continuity through transitions or relocations or disruptions. Of course, there's some things that need to be taken into account in terms of, licensing and states and, those types of things where folks are. But this can really assist with that. So, if you have someone who is seeing a provider or is in a program in a certain area and, now they're moving or needing to relocate for some reason, then this wouldn't be an issue in the same way with remote treatment. So we're able to kind of maintain that continuity. Or folks who are in college, for example. We have a lot of university college students who are, in one place, one state, one area while they're in school, and then elsewhere while at home. And so we can kind of work with that to allow them to continue their programming, even though they may physically be in a different place. And then also just delivering care in real life settings. So being able to really practice and develop skills in one's home environment, which is where the eating disorder is happening and where the eating disorder lives. So they're able to actually do treatment while they're at home and practice those skills in that real life setting rather than, being in a treatment program, brick and mortar, elsewhere, learning these skills, practicing skills, and then still going back to their home environment and maybe having more difficulty with that translation. Lastly, the enhanced support and community. So making things easier to coordinate in terms of programming for family and other supporters. So again, you may have family members or loved ones who want to participate in programming, but also have their own schedules or also live in different places. And so doing this work remotely, we're able to provide, pretty robust programming and options for those individuals to be able to be involved. Also reducing stigma-related avoidance. So by allowing care in a more comfortable environment, we hear that from some of our patients who maybe are in larger bodies or have hold identities that are marginalized and may have reason to feel more uncomfortable going to different places or being in an in-person brick and mortar setting. And so doing remote work, they're able to be in their home environment and maybe feel more comfortable as they're doing the hard work of treatment. And lastly, and relatedly, having this expanded reach really helps to reach a broader audience and therefore allows us to facilitate peer connection through groups tailored to shared experiences. So, for example, we have a pretty large population of what we call mature adults. So that's just 30 and up. But you might go to a brick and mortar setting, and we've heard this from folks too, where there's maybe largely adolescents or maybe young adults, and those older adults may feel less comfortable in that environment. And so with this remote setting, we have a broader reach, and so we're able to bring together people with shared experiences and create, groups where they can really connect with one another, and that can be really beneficial in terms of building that community. So many more things we could say about that, but those are some of the really key benefits that we see with remote care. And happy to go into more detail about any of those if people have questions. But we want to also acknowledge that while there are benefits, there's also challenges and clinical considerations. So things that we need to think about in terms of kind of determining is remote care the most appropriate option for someone in any particular situation. So I will turn it over to Rebecca to talk more about that.
Thank you. So anytime you offer a solution, you also offer a new set of problems. So it's been our due diligence to consider the barriers that might exist in this type of treatment, and to really responsibly look at, can we overcome those, or are they true limitations that we need to make sure we're admitting the appropriate people, or and referring to other opportunities for other individuals. So a big consideration is the digital access, the literacy with the technology, and the ability that those two things give to a patient's true ability to engage in treatment as a whole. This chart here really surprised me, although it shouldn't have. But everybody in my world has a smartphone. But as you can see here, not everybody has a smartphone. If you can see 65 plus, only about 3/4 of individuals have a smartphone. And this is a growing area that we see people coming to our organization. And we have actually found this in practice that people want to come and they're in these treatment deserts, but they also don't have the technology or they don't have the Wi-Fi. So those are barriers that we've had to consider. And then the consideration that the digital exclusion can really happen for people that are in certain areas and can lack the meaningful engagement in our program. So in looking at ways we can overcome those challenges or work with them or around them, we have found that it's really important to do a technology assessment and to really find people's comfort levels with their technology literacy. What devices do they have available? What are they comfortable with? An Apple versus a Google or a Samsung phone? What's their internet quality? Do they need something that might help boost that? Are they comfortable with platforms? These are all things that are really important to know before you put somebody in a digital environment, and maybe they start to feel like I can't completely immerse myself in the environment because of these things. You can provide some of those devices, so provide assistance. More than once, we have shipped phones to people, so it's not a barrier that they can preventing them from engaging in our program. We have also supported hotspots and things like that. Another interesting experience that we had is areas for privacy. So we have a client who is programming from an open office in her provider's group practice. So just kind of being creative for spaces to work with individuals and knowing creative solutions to being able to get tech connectivity in space that's privacy prioritized. Being deliberate in offering orientations and tech support is really important. So being able to have a finger on if somebody's struggling and getting them connected right away with how something works. The virtual environment is so interesting because it's a lot like how we learn. Once you can show somebody how to do something, they can get it right away. But and it's really helpful when you can have troubleshooting guides, when you can have one-to-one or recorded tutorials and drop-in office hours for things like issues with tech or walking through something. It's also important to be able to adapt and pivot when you need. Technology is great, and technology is great when it works. But I think we've all been in that space where the tech is down, and then we feel a little bit hamstrung. So being able to have a good understanding of when you might pivot, how you might pivot, and making sure that it's all clear amongst all participants involved, providers, staff, and patients. What is our pickup when we have a folly, or when somebody's just really struggling? What is a backup for us? And then I know we all know that individualized care is really important, and we can use the tech to also help us have interactive engagement, and create some of the experiences that might connect us in person, in ways that make it feel very connective in a digital platform. I think this is probably the number one question I get asked, is how do you do this in a safe environment? And when I think about safe, these are the pieces that we really think through. Is somebody psychiatrically stable? Is somebody medically stable? Does somebody have a stable home environment where is going to be the treatment environment. And can we integrate their support system enough into their treatment recovery environment? So we're going to talk through a little bit of how we assess that and how we partner with that to make sure that we do have stability in all of these areas. So again, assessment and monitoring is really important. I think that was one of the first things I learned in graduate school is you can't treat the problem until you know exactly what the problem is. And as Caitlin mentioned, eating disorders are a little bit trickier because they not only have the psychiatric component, but they also have the medical stability component and the weight restoration component and the integration of all of those things. And then a lot of times there's some co-occurring conditions. So it's important to have a good assessment of knowing where the vulnerabilities might be to somebody's weight trends, to somebody's vitals, to somebody's potential refeeding exposure. Also, being able to know what co occurring conditions are going on for that person, and if they are able to have enough containment, support, etc., around those things so that when the eating disorder is removed or lessened, and as we know, right, some of those comorbid conditions will sometimes exacerbate. Are they in a supported enough environment? Do they have the skills within themselves? Do they have potentially a team or family support or friend support so that they can safely be activated in that environment? And then, of course, everything through the lens of biopsychosocial well-being and wholeness and treatment. Assessing, assessing and planning for safety. So looking for the risk in the environment and assessing what the risk might be in somebody's home environment. Making sure, so coming as soon as somebody comes on board, knowing what strategies are helpful to you in your environment. A lot of times we have pets that people will have access to. That I would think I've been surprised by how much that is a coping factor. Is somebody having a tearful, hard experience and a dog's snout on their leg. It's just really helpful and to know those kinds of things and how they might be grounded and woven into the home environment. A responsibility and opportunity in a remote care environment, especially when the patient is living with parents or with caregivers, is to also equip those caregivers into the circle of recovery, give them the skills to be a recovery oriented partner of the care team. So really knowing who can you add to bolster the therapeutic component of your work and how can you do that? And then also safety planning certainly is thinking through at the beginning what is negotiable and non-negotiable. What lines are clear criteria for needing a higher level of care, psychiatrically or medically, and having clear protocols in order to do that. And then from a medical lens, being able to have, I almost think of it like a hybrid model. So you are kind of linking hands with people who have boots on the ground, but maybe don't necessarily have the same eating disorder expertise. So connecting with local providers who are there, who can take labs, who can put hands on the patient, but also allowing them to feel supported by eating disorder experts to help care for a patient in the environment that is hopefully going to help maintain their recovery. So having a big ongoing communication, looping them in, making sure that these boots on the ground providers are a part of that medical oversight and medication monitoring. And then before you get rolling with treatment, having a good sense of what local supports are for that patient in their environment, and the crisis resources there. You'd be surprised. There are very different resources all around the nation, and so being able to have thought through that before there's an emergency is really helpful in thinking and acting quickly in the off chance that there is an emergency. Another big thing that we're often asked about is being able to build that therapeutic alliance. So it is true that patients can feel a disconnection in a remote setting when they experience some factors that are disruptive to that therapeutic relationship. Maybe when some of the things like technology or when things haven't been thoughtfully or some of these barriers haven't been removed, they can feel isolated. They can sometimes feel the discomfort of the provider on the other end, coming across their discomfort with the technology. Maybe their own discomfort with the technology is coloring the total experience. Um, there is something about being present with somebody in the room, and we'll talk a little bit about that. Being present with somebody in the room, that's something that a lot of providers and a lot of patients worry about. And then privacy concerns. I actually had was telling Lydia and Caitlin that my door has about 4 feet of barricade in front of it right now because my dogs love to open my door. So that is something, right? That if a patient sees in my background is going to really be concerning that I'm trusting their space and fears to protect that with the privacy that they would expect from an in-person experience.
I'm going to comment on this one just briefly. So the experience of disconnection that Rebecca talked about and that were mentioned on the previous slide all came from qualitative studies that, again, were coming out of kind of early in the pandemic and programs that, had to quickly shift to remote work. And, people were wanting to look into, well, can you establish connection or relationships or have a therapeutic alliance in this kind of setting? And it was mixed. So even in those studies, there were positive things found as well. But this got us curious too. And so, that didn't really seem to match kind of the anecdotal evidence that we had of what was going on within. And so we wanted to actually look into that with our own research. And so last year, we published this qualitative study ourselves. So we looked at data from our patient satisfaction surveys. So this was all data that they, had anonymously provided just as part of their discharge experience. And so we utilized that data. And in particular, we were just very curious, like, are patients able to develop connections in this remote environment in a similar way that they might in an in-person setting? And just sort of what does that look like? And is that perhaps somehow different in this intentionally designed, remote environment where we were really, designing it, thinking about this being remote, as opposed to, again, having to just sort of shift a brick and mortar program due to circumstances. So I won't go into tons and tons of detail here, but happy to, share more or pass along the paper if anyone's interested. Essentially, what we found was that yes, yes, people can develop connections with other clients in care with their providers, and that in some ways it looks very similar to those in-person settings, that many of the same things, like having providers who are genuinely caring and committed and go above and beyond, those that make them feel seen. Patients really wanted to feel, understood and accepted. Those same sorts of themes came out, as well as people really discovering a sense of community is actually the name we ended up using for the title for the paper, because that was a really strong theme. So kind of going back to that benefit I mentioned before of people feeling like they could really connect with individuals with similar experiences in this setting, and felt really comfortable and safe doing that. Again, similar to what we might find in person, people feeling like they made me feel I was worth recovering. So the other clients, the providers, and that was really beneficial and really central to their healing. So those were all sort of similar to what we, have seen or what we would have expected in brick and mortar programs. But there was also this theme that came out around needing to rethink what connection means in a remote setting. So yes, connections can be formed and established and strengthened, but in some cases it might look a little bit different. And so, right, you're not in person. So people talked about like, well, I couldn't give someone a hug or a high five, but like, what could I do instead? Those concerns around like privacy issues and navigating that, or tech challenges, those were some of the things that came up. And so needing to think about doing this intentionally, again, we can't necessarily just take exactly what has been done in person and translate it directly or replicate it directly in a remote setting. We need to be more creative, and I'll let Rebecca talk more about what some of those strategies are.
So we've had the luxury, maybe the opportunity is a better word, of really finding how to build community and therapeutic alliance in the remote setting. We have found that making privacy a priority has been so important. So there's ways to do that, both on the provider's part and the patient's part. So making the space as private as possible, angling away. So if somebody has to be in a shared space, then they have their back to a space that's not with other people. So people can't see their screen. They've got headphones in, so they're not distracted. Sometimes it can be really helpful, especially for patients who might be a little untrusting, to tour the space, to tour one another's space, to kind of see like, this is where I am, this is what this looks like, this is what you. It's easy in this background that we have to not really know what might be happening, or to imagine what could be happening. And an interesting fact, we did some real deep dive into some of the literature to see what's the most beneficial and professional way. And the research was pretty split down the middle about whether or not the use of backgrounds, fake backgrounds, was a deterrent or a helpful component of building rapport. And so we really have given clinicians the ability to kind of think through what makes me feel more professional. So some felt like the office environment gives me a sense of feeling more as a professional. And some felt like this isn't me. I don't feel like the patient gets to see me enough. And as you can imagine, the therapist and clinician being able to show up in a space that feels genuine and authentic is what's the most important piece. And then using the environment to build rapport and support growth. It's cool to see somebody's pet. It's cool to see what poster they have in their bedroom. It's connective to see maybe a framed picture, and to be able to understand who is in that, and why is that picture there, and what does that mean to you. It's been really unexpected, but such a growth agent. Being able to set the same expectations. So validating, right? This can be tricky. This can feel weird at first. Creating guidelines for the relationship. So I can remember as a clinician in a brick and mortar setting, the big whiteboards that we would write and what are the rules. And we worked really hard to figure out how do we do that? How do we help the milieu in a virtual environment figure out how to set group norms and use them in the same way that in a virtual environment. And we have really found that it is easier to disengage in a remote environment, especially in a group setting. It's much easier to hide. So I'll say the settings have to be much smaller, and there's more checking in, more noticing, more. I'll use Caitlin as an example. Caitlin, you're quiet tonight. Tell me more about that. So more coaxing than you would in a brick and mortar or in person. Silence doesn't have the same. It's easier to be silent because of silence. It doesn't have the same therapeutic poignancy and being more intentional and more drawing is really important for the group dynamic to start to catch and thrive. The other piece I wanted to make with that is maybe if Caitlin, who I see, is if I'm not sure what I'm reading from her, I might say, "Hey, I wonder if you might feel nervous, and because I can't see your hands or your legs, it would make sense if maybe you were clenching your fists or tapping your toes. Is any of that going on?" So being aware of things you might not see, but that you would expect to see, and asking people to be more aware and speak more words to that. Um, Another cool factor of leveraging technology is the ability to create more touch points for engagement and support. So chat functionalities, support buttons, creating a community space in a virtual environment. We call it our living room, like you might expect in a brick and mortar, where people go to one space and just kind of hang out. They're not on programming time. They're not in a learning mindset per se, but they're there to just kind of be together and get support from one another and grow from one another. Using the technology as a tool, it's so fun to see this come to life in our work environment and in our communities, in our treatment communities. The emojis that fly during a presentation, or when somebody's saying something heartfelt, and you can see them kind of scatter up, you do feel that love and support. They do land in that way. Also, the chat function, like all of you are having a chat function here. It's another way of communicating, right? I'm speaking, I'm the one saying this, but you can also add your thoughts, you can add your support, you can have a dialogue with your colleagues that are going on, or with your fellow participants that are going on in the chat, as well as adding to the sense of community. And then I struggle with how to exactly say this. So I put be with the patient as much as possible. And what I mean by that is kind of immerse yourself as much as possible. So when I first started to work with people in a digital format, I just let the setting be what it was, which was me and them side by side and talking to them. And I would notice that I'd get distracted. But that really changed when I call it pin the patient, where the patient takes up the entirety of your screen. There's nothing else coming through. There's nothing else, because that can happen. A lot of notifications and pings here and pings there. It's important that when you're with a patient in a therapeutic setting, that's all you see. And it can really feel much more like a person-to-person experience. So these are some of the ways we've made adaptations and innovations. Oh my gosh, we are really, I'll speed up. Um, we have found that things can feel clumsy, awkward, if you try and do apples to apples. So we've figured out how to do apples to oranges. So some of the ways that we've done this, care coordination, like I said, putting boots on the ground, collaborating with local providers, but also being able to have devices that are in the home with the patient that are transmitting data to the treatment team in real time so that we can be there, be present, and get the information to the boots on the ground doctor. Um, it's neat to have sometimes patients' devices can also tell us information, and that's a new sense of technology that helps us to kind of wrap around the patient. And then being really thoughtful and creative with the environment, right? Everybody that becomes an employee at Within gets a ring light. Because when my face is lit and you can see me engaged, it's a much different experience than when my face is dark and I'm kind of shadowed. Caitlin, you can go to the next one, please. This is a really important piece, and it's also a place where we've had some pushback, being able to, or skepticism, and we've been really thoughtful in being meal support in the angles that we ask patients to have, in the continuity between portioning sizes, kind of giving the same expectations across the line, like instead of a tablespoon that might look different at your house and different at somebody else's, imagining a ping pong ball and having that as a visual. Working in many different ways of sending people meals, having meal logins where they take pictures and the dietitian can see what they have, and then also doing exposures in their home environment and providing support in their grocery stores, in their kitchen, in real time so that they can be supported in those experiences. And then again, leveraging the technology. Apps are really not even just within health. They're within health. I know that I've used apps for CPT, cognitive processing therapy, just different ways that it can support resources at your fingertips, guided activities, abilities to check in with reminders to have people check in, connecting you with your clinician, and non-therapeutic opportunities for greater connection as well. And then another really cool opportunity that remote has provided, an unexpected opportunity, is because it has such a broad reach. I have never seen this done in a treatment setting because they're localized to smaller units. But because the reach is so big across the nation, we're much more able to connect people around their shared experience. So this might look like LGBTQ plus group. This might look like the BIPOC group. This might look like recovery at every size. So we're able to connect people who have a similar experience with their eating disorder so they don't feel so alone and isolated in their treatment experience.
All right. I know we've only got a couple of minutes left. So I guess maybe that spoiler I gave at the beginning was helpful. So I'll just quickly circle back to it and then at least leave a couple minutes for questions. So Rebecca did a fantastic job, I think, of really kind of going into the details of what this can look like and what those opportunities are, and the different technologies and things like that. But again, that question may remain for some of, okay, but does it work? Is it effective? And so again, when we look at the literature of, and again, we're here focusing on PHP, IOP, intermediate level of care programs, that transitioned to virtual during the pandemic, those studies did show improvements across symptoms and functioning, weight restoration, showed high satisfaction and high ratings for equality. And those outcomes were largely comparable to those found for in-person settings. So just looking at those programs, that again, this was sort of like a rapid transition, the findings were pretty positive. And there's similar findings for, general outpatient level of care as well. And so that gave us some, confidence, but we wanted to be able to, of course, look at our own programming and see, how we're doing, especially given some of these things like the remote monitoring, our apps, some of these additional elements that Rebecca talked about. So we last year put out our first Within Health Outcomes report, which goes into lots and lots of detail that I won't have time to go into today. So if you're interested, certainly feel free to read through, and always, feel free to connect and reach out with questions. But essentially what we found in that report was similar. So we found also significant improvements for all of our patient-reported outcome measures. And we looked across age groups as well as severity levels. So we wanted to kind of look at, or start looking at, how are we doing not just overall, but how are we doing in serving some of the specific groups out within. Also found significant increases in weight for patients with anorexia nervosa who were needing weight restoration, and similarly high levels of satisfaction with the care provided and high likelihood of recommending the care to others. So we're happy to see those positive outcomes and are continuing to evaluate our programming and look at how we're doing. I won't go through all of these slides unless anyone is dying to know all the details of the data. But we'll just sort of leave us with this as well. So as the clinical research director, that's my job, right, is to be continuing to evaluate and look at how we're doing. And so in addition to that outcomes report, we have done several publications as well as a number of conference presentations. And especially with those conference presentations, we've really, again, tried to look at how are we doing for some of the different groups, for our adolescents, for our sexual minority patients in particular, for those with different comorbidities. What are the things that we're seeing that impact our treatment outcomes? And so this is really important to us to continue to look at and evaluate. So I'm always happy to share more and talk more about that, but I know we've got 1 minute left, so I will go ahead and stop.
Thank you both so much. I really value finding out more about virtual programming. I'm so much more familiar with brick and mortar type facilities and like outcomes and how things are set up more. So I really value being able to get like a glimpse inside of the program and how it was created and designed to be adaptable for everyone and the autonomy that's given to clients throughout their care. Um, you covered the questions that I received. The only one that I was hoping to hear from was really on y'all's personal experience of just what the most interesting, exciting thing that you found from working in a virtual setting versus if you have worked in a brick and mortar setting before. What your most interesting or exciting outcome has been that you've gotten to witness, or relationships that you've seen, anything that you feel like speaks to the experience of working in a virtual environment.
I could say so many things, but one of the things that actually popped into my mind as Rebecca was talking earlier, so going back to that qualitative study that I mentioned, it was fascinating to get to dig through all of this qualitative data, especially because I don't tend to interact much with the patients directly. So to get to hear about their experiences. And there were so many really interesting things that they shared. But one of the things that did come up was the pets, that there were a lot of people that talked about how important it was to their recovery that they were able to do treatment at home and, be with family and be with friends and do all these other things, but be with their pets. That theme came up numerous times, and I think just was not something that had really occurred to me previously and just really stood out.
Yeah, and I would say seeing how important shared experience is, and being able to connect individuals with ARFID in a milieu, and having them verbalize to us like how good it feels to not feel like the odd person out, to have people get them and to know what that experience has been like, and to really feel seen and held and heard by peers who have experienced the same thing.
I love that. I was wondering if pets, when that got mentioned during the presentation, I was wondering how big of a part that was in being able to provide that comfort for folks. 'Cause I know that it can also be a barrier to folks wanting to receive care, is not wanting to be away from their pet specifically and saying, like, this is something that I value taking care of and having that relationship with. And also, yes, I totally hear that on just being able to form these like small groups, or not, depending on however many folks are there, but more individualized specific groups to really connect on those shared experiences. And even from our virtual support groups, I've seen the power of the emojis, and when they all like flutter up, I'm like, oh, it does feel like there's a sense of warmth that gets created in the individual space despite being in a shared space. I love that. I just saw a little heart float up. It
Yeah.
brings warmth to me. We did get one more question that just came in, if you all have time for one more question. How do you all manage licensing with providers? Since there are a lot of states covered, curious about how you all go about navigating licensing with providers.
I wish I could share with you that we have like navigated and figured out some portal to overcome all the licensing difficulties, but I'll tell you, it's the old-fashioned way. We apply for licensure and we get it, and those individuals who get the licenses are the ones who can work with those individuals in those states. So we just work very hard to get people licensed where they can be licensed and work within those stipulations. Waiting for the counseling compact.
We're doing the best we can. Y'all are already doing so much by making services available to folks in different areas based on different barriers to care. So if there's ways that y'all have found out how to navigate getting people licensed where they can, we will hope for a next step. And for right now, it seems like y'all are doing a lot of pieces well and figuring out how to make this structure be supportive in individuals' environments. Thank you both so much for such a helpful deep dive into virtual programming and how available and accessible it can be for folks in our community. I encourage, if anyone has any further questions or is interested in learning more about Within Health, to visit their website, connect with anyone that you're available to there. And if anyone has any questions on the EDF side, please feel free to reach out to us as well. We will do our best to get this presentation up within 48 hours. So look out for a notice on the recording being updated. And thank you all for joining us tonight. And Rebecca and Caitlin, thank you so much for your expertise and for joining us tonight.
Our pleasure. Thank you.
Take care, everyone. Thank you.
Bye.